welcome to Doctor Will See You Now, the next in our podcast series. And I'm really, really delighted to have Professor Joe McDonald here with us today. I'll just dig a little bit deeper into this concept of if you had a sort of an assistant, let's call it an assistant, that could do your basic ADHD assessments for you, that could keep track of your whole caseload and alert you if there were problems. How would that feel as a clinician? Like, would that be, because it really changes everything, right? Like the idea of a clinic kind of goes away. Your days look different.
I mean, I think it would feel pretty good if I was getting rid of all the basic admin tasks, which I'm not very good at anyway.
No.
In particular, we have done something terrible in turning 64-year-old psychiatrists into typists.
Right.
That's a terrible thing. We're unpicking that now. I mean, you'd have to keep a pretty close eye on your assistant.
Yes.
And you'd have to spend some time getting confident that it was doing the routine, easy stuff well before you could let it go. But I think it's inevitable that we'll have to do something like that if we're going to deal with the numbers. I've been a frequent flyer in the NHS this last 12 months with my mother and my father-in-law, who are very old and very sick. I don't think we're in any way, shape or form prepared for the demographic time bomb.
Yes, I agree.
Which is being dropped on the NHS at the moment. And we need to have a serious think about how we do getting old and dying.
Yeah.
Because just as, purely as a visitor to relatives, the hospital seems to be full of very old people who are dying in hospital.
Yes.
And they don't want to die in hospital. They want to die at home. And somehow we've got to make a big shift. Literally, the shift from hospital to community.
Yeah. Absolutely
right. But nowhere clearer than when people are getting very old and dying. Nobody wants to die in the hospital.
No, quite. And I was reading something in the paper at the weekend about the fact that the percentage of over 65s who are renting is massively going up. The percentage of 65s that are in house shares is massively going up.
Oh, that's interesting.
And I think that's another factor in this demographic time bomb, which is not only are we living longer with more comorbidities and therefore we end up dying in hospitals, but as the sort of as the generations progress and people who haven't been able to buy their own house or have ended up in a situation where perhaps they don't have enough money to retire and continue to pay their mortgage, they're living in house shares. It is going to make that problem worse.
No, absolutely. And, my mother's 92. She has very severe dementia. She doesn't know who I am anymore. And she's in a nursing home. And it's been an absolute education to be, on the other side of the NHS, be a customer for a while. One of the things during my career was I was one of the team who founded Great North Care Record. It's an integrated care record, 3.5 million records from general practice shared with 12 trusts, 8 local authorities.
Yeah.
And, it's view only, but it means that in A&E or on the ward, you can see the GP record and you can see their last hospital appointment. You can see what the psychiatrist said to them last week.
Yeah.
And it's game-changing, in terms of the amount of time it saves junior doctors playing telephone tag with a GP. And it's used, a million times a month or whatever. And it's great. What it doesn't do, and I thought it might, and I thought, well, how clever have you been getting everybody's record joined up across the Northeast, including your mother, so you can see all the information. What you can't get from it is what time is the physio going to call?
Right, yeah.
Oh, it's the same time as that she's at the orthopaedic clinic. It's at the same time that she's down at the memory clinic. So I thought care would be coordinated by Great North Care, but it's not. There's an entire layer missing.
Interesting.
In terms of integrating care. My mother suffers from disintegrated care.
Yes.
Despite the local shared care record, necessary, good stuff, cheapest chips as well, actually didn't cost a fortune.
It doesn't have to.
Doesn't. Success usually quite cheap, actually.
Yeah.
Failure is really expensive. But there is another layer missing, and it's this coordination layer.
Interesting.
As a carer, I've got no sight of when things are going to happen. When they're a point. I am the point of integration.
Yeah.
There's nobody else.
That is interesting, isn't it? As a carer, you do end up being the facilitator, the consolidator, the enabler.
absolutely.
And
And I'm the person who's ringing the ward when she's fallen and broken her hip, and I can't get through. And I know that there's a nurse on the ward. All she does is answer the phone all day.
Yeah.
Because people are trying to get information that really they should be able to see somehow. Your mother's gone to theatre. Your mother hasn't gone to theatre. She's back from theatre. You know, all of that stuff. And there's literally usually a body on every ward in the NHS.
Yeah.
And all they do is answer the phone for information that really you should be able to see from home.
And you're an expert. That's the interesting thing. Imagine.
Well, that's the terror. The poor, Joe Public trying to navigate a system. And they, bless them, they think it is a system.
Yeah.
They don't realise it's, 250 independent organisations, empires, all doing their own thing.
Yeah. It takes us back. It's really interesting, I think. It takes us back to this idea of an assist. The coordination layer, and we've done so much plumbing. So Great North Care Record is a great idea. Please don't throw that out for a single patient record. It's working. It's cheap. But why don't we leverage it, and why don't we innovate on it, and why don't we build that care coordination layer using some AI, link it to your scribe? Suddenly we have an intelligence layer that can help the person, whoever it is that's caring for someone or is going through care themselves, on that really difficult, stressful journey. And this is why I think we're going to see this really interesting consolidation of value propositions as we blur the line between the EHR helping the doctor and helping the patient, the care record being a view thing to being something which we can transact upon. I think it's going to be the most interesting sort of 5 to 10 years.
I wrote a paper with Professor Morgan Arnestad, who's a proper academic,
right.
The real thing, not a phony like me. She's the real thing. We wrote a paper called Goldilocks and the Installed Base.
Yeah, right.
And it's about the Great North Care Record and how it came about. But the fundamentals of it are we can't afford to rip and replace everything.
No.
The money's just not there for that. And it's not going to be there for that in my lifetime.
Yeah.
So you've got to work with your installed base. And she wrote a great book, actually, or edited a great book called Working with the Installed Base. She studied every successful and every failed health IT project in the world, and then wrote this book, made this tiny 15-minute video, which, when this goes out, can I send you some links that go with it?
Yeah, absolutely. We'll share them.
There's a couple of key videos, I think, which everybody needs to see. And Morgan Arnestad's 15-minute description of how you do modular, cultivated, on your installed base, maximize value from what you've got is absolutely key. It was a 15-minute video that literally changed my life and made Great North Care Record happen. And it's 15 minutes.
All right.
So
everybody watch that. I'm going to go home and watch that.
Just like a light bulb coming on for me.
Yeah.
Oh, yeah. You can't architect it from the centre.
No.
You have to grow it from little things that are working, and then you join them up. Maybe if we joined them all up, we'd have the single patient record.
Yeah, we would. We have it. This is the thing that I find curious is we do have it. It's to go back to the gardening analogy. The shoots have grown. There's a bit of sort of topiary to sort of entwine them together and trim them correctly, but the roots and bones of the garden are very much there.
I hope that, to be honest, I've been lobbying quite hard. I've come late to the idea, actually, that politics is really, really important. And actually, the politicians, for whatever reason, they don't know anything about health IT.
No.
And consequently, it's on us to try and educate them, to get to know your MP, and to make sure that they've got a slightly better understanding. So obviously I pressed a copy of my book into Chion Wura's hands and said, you don't need to read all 400 pages, just the forward of the last page, all you need. And hopefully that knowledge will help her out. But we need to get to all of them, not least because, I don't know if you're familiar with, I think it's George Stiglitz's work on regulatory capture.
No,
the big corporations, he won a Nobel Prize in the 70s for describing the concept of regulatory capture. Big corporations are really good at getting the attention of the politicians.
Yes, they are.
And consequently, they're very often, the politicians are drawn to the very shiny big thing.
Yes.
And smaller organisations less good at capturing the attention of the regulator and the politician. And I don't think I've spent enough of my career trying to get the attention of the people who are actually going to make the decisions, very often on thin ice.
Yes,
from a knowledge point of view.
I think it's reasonable that if you're a politician, you don't have the experience of someone who's lived and breathed digital health like you have. I think that the interesting question for us as again as a sort of community of people that care about the NHS is individually, I think it's really hard to get that message across. But how do we collectively make the point to our leaders who I believe are trying to do the right thing? I really do. It's just
no, they are.
They're spread so broadly, and as you say, the knowledge is thin. That it's hard to see beyond the big shiny kind of American corporation.
It's really interesting. I'm going to say something outrageous now.
Brilliant.
I miss Matt Hancock. I do.
Matt, we miss you.
I really do, because he sort of got it.
Yeah.
And I'm not sure that anybody else has in my 20 years in the space. He got it that it was about connecting things up. He got it that it wasn't necessarily about buying a great big shiny thing.
Yes.
He understood the word interoperability, and he had a bit of a plan as to how we might go about it. Unfortunately, obviously, it all got thrown up in the air with his political career. But I do think we should revisit the tech strategy that he and his very bright team, actually, some very bright people that he brought in. And I think we would do well to revisit that. I have a fantasy as well as bringing back Matt Hancock.
Bring out the fantasies and Matt.
I'll be drummed out of the Labour Party.
Do the two come together?
Well, yeah. The other bit of the fantasy is that there's kind of a council of elders who've been in NHS IT for 30 years, and when the shiny thing is wheeled out, it's wheeled past them, and they go,
and it is judged.
Yeah, and they say, we did that in 1993 and it didn't work then.
Yeah.
What's changed?
Are you volunteering, Jay?
Oh, absolutely. I've got a team picked out already. They have already met once, actually, to be fair. And to be fair, we delivered a lessons learned session for the people who are doing or tasked with doing the single patient record. And I think it was a really interesting session for them. I think they got quite a lot out of it. Not least what I call the Goldilocks principle. You can have too much money.
Totally.
You really can.
Yeah.
And,
spend small amounts of money really wisely.
Yes.
Spend it with people who are lean.
Modules. Cultivation.
Yeah, exactly.
People who are doing it well.
Yes.
One of my greatest fears at the moment is marvellous things like shared care records in London and the North East and the Midlands, which have been grown for peanuts.
Yeah.
I mean, often with money somehow siphoned out, or
it's sort of a few inspirational CIOs. People.
They've done wonderful things with it at rock bottom prices.
Yeah.
And if you go and spend all the tech spend on the big shiny, which we know from history almost certainly fail, there's a very real chance that the tiny little bit of seed corn that those great projects need to keep going, or better still, to go to Great North Care Record 2.0, add in the integration layer maybe, people know when appointments are, that won't get done because we've spent it all on big shiny.
It would be nice if the government saw best practice and it poured money into like watering those plants. I really love that analogy. And I don't think we do that. In fact, I almost think the opposite happens. I think as an innovator, I've sort of experienced this, to be honest. You get sort of accelerated through all of the things that the NHS does really well. It does actually do really good innovation acceleration. Lots of national programs, clinical entrepreneurs, NIA, Digital Health London, all of these great things. And then you get to a point of scale and suddenly you become the enemy.
Yes.
Which is fascinating. And it's really confusing as an innovator because you're like, well, I've spent 14 years trying to solve this problem because I care about it. I've been told for 10 of those years that, we're an innovation darling. We've reached a certain scale and suddenly we're viewed as a bit of a threat. Yeah. And that's the missing link, I think, in the NHS's innovation journey is once you have things that are breakout successes, it should be desperately trying to support those interventions, those products, whatever they are. And there's lots of different forms of innovation, right? And it should be listening to the people that did it and helping and they should be part of the conversation about what we do next.
Yeah.
But we don't do that. We do exactly what you said, which is we see that, we then go, oh, they're a bit big and we're a bit nervous of them. Let's go and buy something from big systems integrator over here.
Yeah.
And then I think the other thing that the government can do, and it's I find it very confusing that it doesn't do this more in health, is rather than trying to build stuff, it can regulate. And to regulate for interoperability, and I want to just sort of bracket this by saying, I think interoperability in the NHS has come such a long way from where it was 10 years ago. I really think that you can't thank one particular person for it, but the ability to integrate systems is so much better than it was 10 years ago. But, it's still hard with certain EPRs and certain vendors and people that don't want to play ball. And the one thing the government could say is, we mandate that you have to have open standards.
Yeah, totally.
And it sort of blows my mind that they haven't done that, because governments are very, very good at regulation. And that is an area where regulation would stimulate significant innovation, I think.
I think you're absolutely right. I mean, over the years, and it's all in the book, we've had a number of attempts. It must be 10 years ago. We wrote a thing called the Newcastle Declaration on Interoperability.
Yeah.
As a group of CIOs and CCIOs at Digital Health Summer School one year. And it was two sides of A4.
Yeah.
Basically saying, if you don't play nice, you shouldn't play at all.
Yeah.
And we haven't really applied it. Everybody said yes. All the big suppliers said, oh, yes, that's
we'll do
but
that,
then they didn't do it.
Yeah.
And the government haven't really done anything about it. We've continued to give great chunks of money to people who haven't really bought in
exactly
to interop. And I think that is something the government clearly could do and should do going forward. Yes, we've got our install base, we have to live with it, but we can't insist on some things.
Exactly. As a government, you have sticks and carrots, right? So you have your incentives and your payments and your tariffs, which are one of your big levers, and then you have your sticks, which are your regulation. And I just don't think that. Maybe it's because there's quite a lot of nuance in this conversation, actually, but I don't think the sticks and carrots have been well applied over the last 10 years, which is a shame.
I think that's right. And Seamus O'Neill, who used to be chairman of the Academic Health Science Network in the Northeast, has a great slide, actually. He's got 3 pictures on it. There's a cake in the first picture. There's Apollo 11 in the second one. And in the third one, there's a child being carried by his parents. And the headings are: simple, baking a cake.
Yeah.
Complicated, putting a man in the moon. Health IT, raising a child. And that's how complex this stuff is. And I think you're lucky if the health minister gets to Apollo 11.
Yeah.
Complicated, but a very clear thing to do.
Yes.
But put a man on the moon, bring back. So it's a very clear thing to do. Health IT, much more complex, much more like raising a child.
Yeah, nuanced. And sadly there isn't enough people with the skills, I think. This is the other thing. When we go and talk to our clients, most of them have a fairly clear idea about what they want to do. Yeah. They don't have enough funding, for one, but then there's a skills gap. And, implementing the technology is the secret to this. I don't think any of this is really a technology problem anymore. We've got some cool things like AVT and scribes, but actually, building on modern cloud infrastructure means you can build these things quite fast. Yeah. The implementation is so difficult and is under-resourced, I think, and that's often where we fall down.
I think that is so true. I'm glad you brought that up, actually, because there's a critical layer of infrastructure, and it's the social infrastructure provided by communities. So Great North Care Record is built on an infrastructure of people who know each other, trust each other. If you're going to share information, 3.5 million records across 12 organisations, and you're thinking, well, do I trust Sunderland City Hospital?
Yeah.
Well, yeah, I know Andy.
Yeah.
He's a good guy.
Yeah.
He can be trusted with really sensitive information. Can I trust the people in Northumbria Healthcare? Well, yeah. I know Dennis, he's a really good guy. And so on. So these human infrastructures of trust underpin all progress in health IT projects, but we always forget about them and realise how important they are. One of the most important groups of people in the northeast of England that make all that information flow around the region. 3.5 million records, nobody opted out, or virtually nobody opted out. every trust has an IG guy
Yeah.
or girl, and they have become a community of people who can trust each other,
Yeah.
share a set of values about what information sharing is. And if you don't have that community, you can't share anything.
And hasn't I want to shout this out because I think information governance has come such a long way. You know, the IG guys and girls were a little viewed as the enemy at one point.
Yeah.
And that community has modernized, organized. There's a high level of trust.
Yeah.
And IG now in the NHS is it's not universal, but broadly speaking, it's pragmatic. It understands its role. Same as clinical safety.
Yeah.
Actually, I think clinical safety has come such a long way. And
well, one of the things I'm really proud of that's happened over the 20 years that I've been involved is, I mean, I knew Fiona Caldicott. I've had dinner with Fiona Caldicott.
Yeah.
Her reviews were so sensible. She's a psychiatrist like me.
Yeah.
She understands how confidential some stuff is. She really gets it. But every time, she reviewed the legislation, we made progress. We made progress at a pace that the public could cope. So the weather's changed. When I started, nobody wanted to share anything.
Right.
All GP records were locked down. Now it's routine. You expect your information to turn up in A&E out of your GP record. So the weather has changed, but I do worry that sometimes if you go for the big data land grab, you frighten the horses again, up pops the IG issue, and we go backwards. Like care.data took us backwards quite a lot. So the government still need to be careful with people. I mean, I remember we did a survey back in the day, GNCR, getting off the ground. Would you be happy for your care record to be shared for research? 83% said yes.
Yeah.
Most of the rest of them, you can probably persuade. There's about 3% of people who are really passionate about privacy. Just let them opt out.
Right.
Put a proper opt-out in place.
Yeah.
Everybody else can set their privacy settings to share everything for research, get free prescriptions.
Yeah.
And you create the massive consent-rich database of research, which would be the biggest, best research database in the world, with consent to ring people up. Yeah. You've got an interesting genome. We'd like you in the trial.
People would be delighted.
I think they absolutely would. The NHS could also make a fortune as the best place in the world to do research.
I think the point you made there about communities of trust is so important because, if it's your local hospitals in your local area getting together to do a better job, almost no one has a problem with that.
Yeah.
It's the whole point about these central projects. When it then becomes the government is forcing something on people, not only does, as you say, the public sort of put its hackles up, rightly so.
Because Farage has got your record.
Exactly, right? Like nobody wants Nigel to see what's been going on, let's be honest. And so rightly the public push back and long should the public push back on the government doing certain things. But at the same time, that community of CIOs who trust each other, they're looking at this thing and going, well, we don't know these people, we don't trust them. And so they're less likely to make progress. So I think that point you made there, Joe, is such an important part of not just bringing the public along, but actually making the change happen, and is missed again and again and again.
Yeah, and I think governments do miss out on it. Oh, God, if I hear about Estonia again, I will scream.
Right.
It's possible on a scale.
Yeah.
I think between 1 million and 5 million is about the right size for a big shared care record / research project. You can get all the data you need in a population that size. You can get the trust of the people whose data it is.
Yeah.
The minute you try and go up to a big national scale, you very often run into problems, not least because there's then too much money sloshing about in the project and
exactly.
people go weird.
And enable the people on the ground to do stuff. Don't give them $1 billion or £1 billion because they go a bit crazy, and let's actually let the innovation happen. That's absolutely right. I want to take us back a little bit to neighbourhoods, because we talked a little bit about that, and we talked a little bit about integrated care, but this is the other big shift that's apparently happening at the moment, right? Which is from the hospitals community, the idea of a neighbourhood health service. I think that we can all agree it's better if people get care at home and they don't have to come into a building to do that. I think that's right.
And hospitals are dangerous places to be.
Hospitals are dangerous places, intimidating places to be. It's really stressful just trying to park is quite stressful, to be honest. But walking into a hospital, if you don't do it every day, is a scary experience.
And if you're 95, you're very likely you'll get confused straight away.
Yeah,
you'll immediately lose your marbles.
Yeah,
it was astonishing. I watched my father-in-law do it. He descended into a paranoid psychosis.
Really?
In 12 hours.
Really?
Within 12 hours of admission, there were other things going on that were affecting his brain chemistry and so on. But it was chiefly, he was no longer in an environment he understood. He immediately became paranoid.
Yeah.
And we were all out to get him and trying to fill him out of his money and all the rest of it.
Right, which is horrible for you to watch.
Yeah, dreadful.
Terrible for him and not a sensible way to run a caring health service. So I think we all agree if we can look after people at home, that's better. To our point of using the technology and the assistance, in theory, they should work when people are at home. I think the bit that's missing at the moment is we have this aspiration of a neighbourhood care service, but we're not clear enough about what that means, are we? And I don't think we're clear enough about how we leverage some of the things we have, like the EPRs and the shared care records and tools like ours, versus building new technology and new infrastructure for that. What's your take on that whole movement?
I love the 10-year plan. Not really a plan; it's a vision.
Yeah, aspiration. Perhaps.
Yeah, we need something more concrete. I think some of that is coming now. Actually, the framework they published last week begins to offer a direction of travel. I love the idea of neighbourhoods because that's where people live. That's where my mother lives, in a neighbourhood, and she's surrounded by a dozen organisations who don't really communicate with each other. So I love the idea of it genuinely coming down to a team around the patient. So we call it the constellation of care.
Yes.
Around my mother. There's about 4 or 5 organisations, maybe 20 individuals, physios, 2 psychiatrists, the orthopod, the community dental service, the nursing home, the Little Sisters of the Poor, probably never going to be able to afford Epic.
Maybe better for it, frankly.
Yeah, but that neighbourhood team is different for every patient.
Yeah.
And the bit that is missing for me from an IT point of view is the NHS community WhatsApp, if you know what I mean. Because the joy of WhatsApp is that whenever you've got a new team, you just set up the group, and then they're all communicating with each other. And that's the kind of fluidity of the constellation of care, the stars of your family care are literally disconnected. And I'd like to see them connect. Then I can retire.
And what's stopping us having that sort of WhatsApp? Because it's really interesting, isn't it? I've got 2 young kids, and whenever you go to a new childcare environment, the first thing they do is they set up a little WhatsApp group. It's the first thing they do.
Yeah, totally.
Here's Ellie's WhatsApp group, and then during the day, here's a few photos of her. What's something does she like this for lunch?
The NHS is running on WhatsApp too.
Right.
Every ward has one. Every rota has one. And I'm sure they're not putting anything clinical in there.
Should we say it out loud? The NHS is running on WhatsApp.
Well, pretty sure.
And I think that's fantastic, right? Yeah. That's really good. So is there a version of that where we're bringing the carer in to those groups?
I think there has to be, because they're at the moment the person who's generally the care coordinator between these disparate organisations. We need some sort of clinical weapons grade WhatsApp that can write back to EPRs and to the shared care record and what have you. But it is the bit that's missing, and it's so missing that NHS staff are filling it in with WhatsApp at the moment, and it's fascinating.
I guess people are a bit nervous. People have been nervous about WhatsApp because of
my inner medical director did get nervous when you said it's great.
I can see you've actually sat
no, I did. I was like, oh shit, no, don't say that. Because my inner medical director is, I need to own all the comms here,
right? but almost to your point about the AVT stuff, where you've got people lining up to use it. If you've got users doing a thing. What did you call it? Goldilocks and the
installed base.
And the installed
base is WhatsApp.
The installed base is there.
Yeah, I should apply my own principles and be less afraid.
I think the issue that we have with it, clinical risk stuff, I'm not qualified to talk about. The challenge I think we have is then for it to become a tool which is used outside of a trusted group, because those are all trusted groups, right? It's a team of clinicians that work together.
It's not stated, but it's actually a circle of trust.
It is, yeah, and we all know these WhatsApp groups exist in all sorts of ways, and if you're on the inside of them, you're in the circle of trust, and if you're not,
that's right,
you're not.
And there's a separate one where they talk about you.
Yeah, exactly. So Russian dolls of like um, um, and so to bring the carer into that circle of trust is a really interesting thing. And perhaps that's the opportunity around going. I don't want to sort of over-index on AI, but where my mind went was if you've got this AI sort of supporting you as a clinician in your role, the AI almost being the filter between the person and the clinician is an interesting idea. So as a carer or patient, I'm talking to this sort of AI assistant, which is hearing my needs and then sort of summarizing them, possibly triaging them, for want of a better word. And then as a clinician, you can then respond in a way that feels like you're not opening up the floodgates to tens of thousands of messages from all of your patients, whatever time of night.
Well, that's why we don't collect their email addresses, isn't it? In case they email us.
Yeah, petrified of getting an email from.
I mean, we're the only business in the world that doesn't collect the customer's email address.
It's crazy, that, isn't it?
It is. I get it.
Yeah.
People don't want to be overwhelmed. They're already overwhelmed, to be fair. And one of the reasons why I think things are so difficult at the moment was so beautifully described in Darcy's report. Is he said that NHS staff, and I noticed the juniors are on strike today, NHS staff have withdrawn discretionary effort.
Yes.
The goodwill that used to keep the NHS on the road, the extra hours worked for nothing, actually, that's dried up.
I think that's really scary. I picked up on that too. The fact that the NHS basically does run on people going the extra mile. And
they ran out of gas.
They ran out of gas because they sort of got the piss taken out of them a little bit.
Yeah, no, absolutely they did. And they all quote the same moment when they lost faith. It was when they got clapped instead of pay rises during COVID.
Right.
It was the clapping that did them in.
Yeah.
When you talk to them. Two of my children are junior doctors.
Yeah.
One of them's in Australia.
Really? Okay, that's very sensible.
Yeah.
But it's true, right? Like I was outside clapping with the rest of them. And
so was I.
You know, and but in retrospect, we put these young people, and older people, we put our clinical workforce through a terrible, terrible time with very little thanks.
Sometimes with terrible, terrible digital tools as well.
Yeah, exactly.
And, you know, the EPRs have become a significant cause of burnout. We know that from some of the surveys that we've done in recent years. And that's a terrible thing when you think about it. And I feel partly responsible because obviously I was part of the national programme that gave everybody a mental health and EPR. But
it's tricky, right? Because also if we were all still practicing on paper, we wouldn't be able to take advantage of ambient voice technology.
Absolutely. And mental health are really well set, actually, better than probably the acute sector.
Like if you do any change management, I'm a bit of a change management nerd. Any change management program, you have, everyone's excited at the beginning and then shit hits the fan and you go through this like horrible despondent bit. Yeah. And whether you succeed or fail is, do you get out of the dip? Yeah. Even the most successful projects have a dip, always. Yeah. And you get through the dip if you trust each other, if you have great leadership, if your scope is tightly constrained, all of these different things. And I think what's happened with the digitization of the NHS over the last sort of 15 years is we've got some stuff wrong. We've got a lot of stuff right. We've been through a big dip. But actually, as you say, mental health is now in a place where it could adopt AVT in 12 months. And that would not have been possible if we hadn't done that.
Absolutely
15 years
not. Going right back to my very first encounter with digital health was when we put in Rio in my trust 20 odd years ago now. Yeah. And people stood up in the consultants meeting and said, this is a disgrace. You'll never get me up in one of those. Yeah. And the same guy who badmouthed Rio and said we shouldn't have an EPR. And the Royal College of Psychiatrists were officially opposed to electronic patient records when I took over as national clinical lead. I had to go and see and convince them how to buy the sandwiches for the meeting because Connect for Health didn't have a sandwiches budget. They had billions for big American software,
but no money for
sandwich budget for the Royal College to get a few people to come to a meeting.
What a metaphor for trust. What a metaphor for trust, to the point you made, right? Like, we've got the money for this technology, but we can't buy sandwiches for these people that are skeptical.
No, absolutely. But when we were putting in the first EPR, we put Rio in, consultant stands up, said, no, this is a terrible thing, confidentiality, viruses, all of it. I hate it all. I saw him 10 years later at another trust, which was still on paper. And he was saying, what we need here is an electronic patient record. So the weather has changed. They're about to get lots of lovely toys from a admin point of view, and things will be comparable, even maybe better than being on paper.
Who'd have thought it? I mean, I think as we begin to wrap up, that is a cause for hope, right? Like we're through that trough of disappointment. The NHS is actually, I think, beginning to make some really great decisions again. I feel like it is open to innovation. There's some systemic threats, but there are so many reasons to be hopeful. And that sort of vision you've described of, as a clinician, I've got my admin being handled by the technology. I'm caring for my patients remotely. I'm aware of who's at risk and who's likely to come into crisis, and I'm able to proactively.
My secretary is training as a nurse.
Yeah, secretary is training as a nurse. Everybody is moving up the value chain. We're all doing high value, ultimately human things. I mean, that's what we've been aiming for, right? I think that's something to be really proud of.
Absolutely. But one of the reasons why I couldn't retire was because we were in the trough a long time. And then I saw what was coming. I saw the gorgeous tools that were coming. And I thought, I'm going back on the register, man. I'm going to practice in the modern age.
I think that's any reason to be hopeful is that Joe is back in clinical practice. What advice, to sort of close us out, would you give people that are starting their digital health journey, clinicians, managers, informatics professionals that are...
Go to meetings about digital health, talk to people you don't know.
Yeah.
You only get new information when you talk to the people you don't know. So it's terrible advice in most circumstances, but go to meetings, talk to strangers. Not what you would normally tell your children. But in the digital health world, because there's not a set career path through it, the best way is just to go to the right meetings and talk to people, join the right networks, join the digital health CCIO network or CIO networks, and make friends with people you don't yet know. That's always my advice. If I ever occasionally used to open summer school, and I used to say, talk to strangers.
Yeah, talk to strangers. Go and make it happen, because it's networks of trust.
Yeah.
And most importantly, buy Joe's book, which is
Fire and Loathing in Las Vegas.
Fire and Loathing in Las Vegas.
Why is it called Fire and Loathing in Las Vegas? Is normally what comes next. And the answer is, fire obviously is a corruption of Fear and Loathing in Las Vegas.
Fantastic book
by my favourite gonzo journalist, Andres Thompson. Las Vegas, because you don't really understand the health IT market until you've been to HIMSS in Vegas.
Right.
And you've felt the pile on the carpet at the Epic stand come up over the welts of your boots. You don't really know where the NHS stands in the world of health IT until you've seen the 72,000 delegates and the keynote speech by Donald Trump.
Yeah.
Actually, that was the year he got cancelled, but he was due to be the keynote speaker.
Was he?
That's how much money is involved in the top end of the health IT business. And it's too much money. And it's from we're taking our lead from a country who get terrible health outcomes and spend more money than anybody else.
Yeah.
And I just think there's a real opportunity for the UK to lead the world, actually, in health IT.
I completely agree with that. US, 17% of GDP, single biggest reason of personal bankruptcy is healthcare.
It's a disaster.
Yeah, it is.
And I think we've got a real opportunity here. And I know things are bad at the moment, but they've been bad before, and they did get better.
And they did get better. That is a brilliant note to end on. I'm going to ask you one last question, which is, if Hunter S. Thompson was to come to the UK in digital health, what would he say?
Wow. He obviously dropped some acid.
Yeah.
And much of what he would see would be exactly the same: monsters and iguanas in the bar, and a great deal to be afraid of, but a great deal to enjoy as well, I think.
Yeah, I think so. Iguanas in the bar, but we're out of the trough, and the future looks really bright.
Yes, I think so.
Joe, thank you so much. That was fantastic. I'm so pleased to have had you, like real digital health royalty, and go and buy the book, Fire and Loathing in Las Vegas. Thanks very much.
Thanks a lot.